morning, everybody that's gathered here in the Bechtel boardroom. We are going to get kicked off on Donuts and Development. I'm Carl Dye from Tridec, almost said from Cadillac.
That works too.
Our guest today on Donuts and Development is Reza Kaleel. He is the Chief Executive for the Southeast Washington area for Providence. Here in our service area, Cadillac obviously is the Providence Hospital, and then I should know the name of the hospital in Walla Walla.
Providence St. Mary in Walla Walla.
Providence St. Mary in Walla Walla. So Cadillac is our sponsor today, and we're really honored to have Reza on to kind of give us an update on the healthcare scene in general, from Providence perspective, as well as just from a healthcare provider in today's service area. A lot of challenges, maybe, and opportunities too, I think.
Yeah, it's good to be with you.
Yeah, no, thanks for both being our sponsor and for joining us today. Because as we talk about all the time, when we work with new companies that are coming in the Tri-Cities, healthcare is such a critical part of our community that we try to let people know the services that we offer. You guys are obviously one of our critical providers here. So this is really relevant to all the work that we do. Thanks for everybody joining us in the Bechtel boardroom. As always, a packed house here in the Bechtel boardroom. Just very few open seats, and thanks for everybody joining us online. Reza has some slides that he'll go through, kind of an overview for us, and then we'll open it up for questions. So if you think of any questions while Reza's going through it, hold it until we get to that point. And then if you're online, if you're on social media, you can put it in the comments section. If you're on a webinar, you can use the question and answer feature. We'll get to all the questions that we can. So Reza, I think you've got the clicker, and why don't you take it away and go through your slides?
Yeah, but before we do that, I want to just introduce some members of our team that are in the room. I know the folks on camera can't see, but for those that are in the room, you can see a few folks I want to introduce. So we have Lisa Diamond, who is our executive office assistant, and she also is our liaison to our boards. She's here with us this morning. Spencer Harris, our chief financial officer and lead for strategy, is with us. Emily Volland, our leader for communications, is here with us. And Lacey Perry, our chief philanthropy officer, who leads our 3 foundations, is here with us as well. So if you have any really hard questions, please direct them towards those folks over there, and we'll go from there. So yeah, for this morning, given that this is a Tridec audience, I thought we'd really focus a fair amount on the economics and kind of what we mean from a development standpoint in the community. So I want to talk a little bit about some of the overarching economics in healthcare that drive a lot of the dynamics and challenges we have. Some of the impacts of the current overall economic climate that is impacting not just healthcare, but others that have that specifically impacts us. I want to talk a little bit about just a profile for our service area, as you mentioned. So Cadillac and Providence St. Mary, and what we are as a collective entity here serving Southeast Washington and beyond, and then a little bit about our areas of the focus for the future. So I'll take about 25 minutes, probably, Carl, and then plenty of questions and answer time towards the end. But I want to start with a quick story. And Carl, you're in the story, actually, so you're going to have to play along. So it's a story about a Ferrari dealership. It's a very special Ferrari dealership where reality gets bent a little bit because it's a Ferrari dealership in the Twilight Zone.
Oh, wow.
So Carl Dye wanders into a Ferrari showroom.
That would definitely be a wandering for me.
And he doesn't know anything about various car brands and what they cost, and he just knows he needs a car. So a well-tailored salesman approaches him, and Carl says, "How much for one of these red ones?" And the salesman shakes his head and says, no, we don't discuss prices up front here, but don't worry, everyone who walks in leaves with a Ferrari. So you're in good hands, Carl. Carl says, really? He's kind of bewildered, but they say, indeed, it's actually the law. You simply enter this dealership and you're entitled to a Ferrari. What if I can't afford one? Says Carl. Well, do you have transportation insurance? The salesman says. I'm not sure. Carl hesitates for a moment. No worries, my friend. I'm not supposed to ask you that question now anyway. Hands him a clipboard. Sign here. We'll sort out all the details later. So Carl is swept up in this whirlwind test drive and comes back after a exciting time out on the road and hands the keys back and says, you know what, I'm way too tall for this little car. And actually, I need something more practical for here in the Tri-Cities. So the salesman says, that's fine. He casually hands him an envelope. Carl opens it. $400,000 I never agreed to this. Well, that may not be the price in the end, Carl, don't worry. But you did sign for the Ferrari. So Carl says, this is madness. And the salesman says, just relax. Maybe your insurance will cover it. Or not. You'll find out soon enough. Behind the curtain, while this is going on at the dealership, we have the dealership CFO. And he's looking at a stack of unpaid bills from other folks like Carl who are given Ferraris that they can't possibly pay for and wondering how to keep afloat. So to survive, some of the customers are going to pay the full sticker price. Some with the top tier transport insurance are going to have higher inflated costs to make up for those that don't pay at all. Some are going to haggle and get substantial discounts, and some are going to find themselves chased down by collections. Hopefully that won't be you, Carl. CFO sighs deeply and just says, without overcharging some people, we're going to have to close our doors. So this is kind of a silly story, but it's a way of articulating really how a hospital emergency department works. So the EMTALA, the Emergency Medical Treatment and Labor Act, which goes back to 1986, is a law that requires all hospitals with an emergency department to provide care to stabilize and treat patients, regardless of ability to pay and so forth. And it's a wonderful thing. It allows, from a safety net standpoint, us to have a society that's able to care for people at that end of the spectrum. But what we don't do really is provide any guarantees for primary care, wellness, preventive care, all the things that would probably be much more helpful than kind of the catastrophic things we focus on. So that's one of the things that really, for hospitals in particular, really is one of the underlying forces that drives a lot of the costs and drives a lot of, I'm just going to say dysfunction, I guess, in the healthcare system. Another piece is just the way insurance works. And I'm going to ask you a few questions, and those in the room, feel free to play along here. And if you're online, you can think about this in your head. But for Washington hospitals, what proportion of hospital patients overall are on Medicare and Medicaid? So this isn't folks necessarily with that insurance, but people that come to the hospital that are Medicare and Medicaid. Any guesses? 1 out of 10, 7 out of 10, 3 out of 10, 5 out of 10?
I go with 5.
Okay, Bob says 5. Got a few for 5. Actually, 7 out of 10. So if you're walking to the average hospital waiting room right now in the ER and there are 10 patients sitting there, chances are 7 of them are on government insurance, likely Medicare or Medicaid. And you can see Medicare and Medicaid, the payments that they provide don't meet actually the cost of what it costs the providers to provide the care. So that the shortfalls from Medicare, you can see on this slide a little bit. Medicaid, there's been some up and down, back and forth as funding has changed, but largely they don't cover our costs. Next question. So commercial insurance, obviously hospitals have to make up the difference somewhere. And so employers that provide commercial insurance or folks that purchase commercial insurance, they pay more than Medicare and Medicaid. How much more do you think that is? 50% more, 33% more, 250% more, 75%? Any guesses?
50.
Carl says 50. All right. 33.
There you go. That's right.
All right. 250%. And this is one that I think is surprising to a lot of folks when they see this. So nationally, commercial insurance on average pays more than 2.5 times the rates that hospitals receive from Medicare and Medicaid. And you can think about it in terms of proportion. So proportionately, we have far fewer commercial patients than the Medicare and Medicaid to make up the difference and be able to sustain the system we have. This has been going on for years. So employer-sponsored commercial insurance really started to become a thing after the Second World War. One of the things the government did at that point to try to curb inflation was cap wage rates. And so employers at that time started offering things like insurance and other things to be able to attract employees. And this is when this kind of unofficially caught on. And for the years since, it's just become part of the fabric of US healthcare, even as we've implemented things like Medicare and Medicaid and so forth. So underlying dynamics, just important to understand as we think about this. And you all are, I'm sure, familiar with, you've seen all sorts of things over the years about the cost of healthcare in the United States being more than most developed countries. There's a variety of reasons for that. One of them that I like to point out is really the high administrative cost associated with healthcare in the United States. largely related to this scheme of insurance where all the providers are having to balance billing so many different insurance policies and approaches, and the amount of administrative costs it takes to kind of work in that very complicated world. And there are other things as well, but thing to call it today. I want to talk a little bit about the state of Washington and what's been going on the last few years. So if you look back over the last 5 years and think about the COVID pandemic coming into now, really the hospitals in this state have not fully recovered from that. We're not an exception. This is some information from the Washington State Hospital Association about operating losses that hospitals have sustained in the last number of years. And I'm not going to read all the numbers to you there, but in 2024, if you annualize that, about a $1.2 billion loss cumulatively across all the hospitals. And in 2023, I don't have more recent information than this yet, but most of the hospitals, 81%, were operating on negative margins. We are very fortunate here in our service area. We are in that 13% that have low margins. So we run on low single-digit positive operating margins. And through that, we have to do everything from make sure that we're paying all the wage increases to our staff, make sure that we're able to sustain other inflationary pressures. And then in communities like the Tri-Cities and Walla Walla, I think looking at actually having to expand care to meet, in this community, the growing population, in Walla Walla, the aging population, all those things, trying to keep up where we really have become a big part of the healthcare safety net here with St. Mary and Walla Walla actually is the only hospital in that community. And here we have a very large presence as well. This is a metric, again, this is for hospitals across the state of Washington. This is days cash on hand. And most of the hospitals across the state have been really living off of their savings over the last number of years as these operating margins have been lower. So the ability to continue sustaining that is pretty limited. You can see the brown bars here represent the year 2019. The blue is 2024. And if you look at the number of folks that have shifted out of that 200 plus days cash on hand into the lower, we are right now, Providence, the bigger organization that we're part of, is right in that 90 to 120 days bucket where a lot of the hospitals and health systems have shifted. And with that continuing to decline, we will not be able to continue investing in the types of things we need to be sustainable for the future and be here to take care of the population. So there's a lot of focus right now on operational recovery and trying to get back to positive margins where that days cash can be replenished, not only as a rainy day fund to survive the next emergency or pandemic, which is essentially what happened. We had this emergency for a number of years, which drew down those savings, but in order to be able to raise debt financing to build new facilities, do a lot of things, we have to have days cash that show the lenders that we're in good, healthy shape. From an operating standpoint, we look very much like this. So I'll just share the Washington statistics. Over half of the expenses in hospitals and health systems are on wages, salaries, and benefits. Shouldn't be surprising. We have a lot of very highly skilled, highly educated staff that we employ. And then we're also one of those rare industries that's both very labor and very capital intense. If you think about the technology that we have to keep updated and refreshed, the types of supplies that we use, and so on and so forth. So definitely a expensive service to run. And the inflation has been, like everybody across healthcare, we've sustained a lot of this, probably a little more pronounced in healthcare, particularly during the pandemic, where we had spikes in the cost of what we call travelers, so per diem staff, nurses and other folks that you bring in on a temporary basis. But our overall wages have gone up considerably along with everyone else as we've come through the last few years. And there's a lot of uncertainty going forward, just like everybody else. Again, looking at what's going to be the impact of tariffs potentially on some of our supply expenses and the things that get imported in particular, continued pressure on wages and other things as we look into the future. Then on the revenue side, there's a number of risks. We're just absorbing some of the decisions that have been made at the state level, and then the governor still has to move some of that forward. But we think Medicaid at the state level has been protected largely. There's a lot of discussion. The federal level, and Medicaid is a program that's collaborative between the federal and state levels, and there's a lot of dependencies there. So we're watching very, very carefully as all the health systems are, on what could be at risk with Medicaid. The bigger concern, I think, for me, other than just worried that we'll have more uninsured folks coming through our doors, is folks that lose their healthcare coverage are known to pursue less wellness care, less preventative care. They have less access to primary care and all those things. That just causes your community health status to worsen. Another impact could be as more people lose that status, if that were to happen, they start seeking care. Back to the emergency room story in Carl. They start showing up in our emergency departments because they don't have anywhere else that will accept them. The waits in the emergency departments for folks with true emergencies and other things become more challenging as you have folks that are perhaps unnecessarily seeking care in an ED. So a lot of attention on this right now on the revenue side. And of course, major negotiations going on between health systems and insurance companies now trying to get some of those rates up as we've seen our costs and everything increase. A little bit about our organization I thought I'd share as far as our profile goes. So CADLEC has been in this community since 1944. So really in response to the Manhattan Project that was here. So in that year when things began and the population in Richland went from about 5,000 to about 50,000, that's right at the moment where the hospital was built. You can see in the bottom left of the photos there, that's Lieutenant Colonel Harry CADLEC from the Army Corps of Engineers, who was one of the folks most responsible for building the city of Richland and the hospital. He was unfortunately the first person to actually pass away in the hospital at CADLEC. And so he was named, the hospital was named after him primarily because of all his work establishing and setting that up. In the top right is Mother Joseph, the Sisters of Providence, who came to Walla Walla in the 1860s, actually starting with some things the sisters were doing around education. And then by 1880 had established Providence St. Mary Hospital there, which has been there. It's one of the longest standing ministries within the Providence system, and something that we take a lot of pride in. And what we've grown into today, there's a few statistics on this sheet. I'm not gonna read these all to you, but CADLEC is a level 2 trauma center, so really has a regional catchment area that includes our area immediately in the Tri-Cities, but we get about a quarter of our patients from outside the area as well. You can see that by size, about 337 licensed beds. We don't operate all those yet, but we have the ability to continue growing into that. Providence St. Mary Medical Center is licensed for about 142 beds. Community hospital serves Walla Walla, but also a little bit into Oregon, as well as they have some services that draw from beyond. Neither of these hospitals are what you would call, you hear the term critical access hospital. So a critical access hospital is a hospital that by law has to have 25 beds or fewer. There's some different economics that they work under in terms of cost plus reimbursement to try to preserve rural access. Sometimes I will hear our hospitals referred to using that term, particularly Providence St. Mary, because it's the only hospital in a rural community, but it's substantially larger than a critical access hospital and provides on-call services and a kind of a litany of things that you wouldn't see typically in a critical access type hospital. So between our two hospitals and our medical groups, there's a lot of care that's provided here in Southeast Washington. Just some stats on the size of the organization. This is Southeast Washington in total. If you think about these numbers, about 3/4 of these tend to be CADLEC, about a quarter St. Mary, but this is us in total. So nearly 5,500 dedicated caregivers or employees. Licensed beds, we talked about. Very busy emergency departments, 3 in total. So we have an ED at CADLEC at the main hospital in Richland. We have a freestanding emergency department in Kennewick. And then, of course, the emergency department at Providence St. Mary. So this is inclusive of all 3 of those. Then a little bit about our other statistics. So it's always impressive to me to see over 1 million ambulatory visits a year between all the clinics that we have in all our locations. Here in the Tri-Cities, we're the second largest employer next to PNNL. I think if you had the Hanford side on here with all the various contracts together, they're obviously larger, but no. There's a variety of groups there. And then Providence St. Mary is Walla Walla's 3rd largest employer. And we are a not-for-profit healthcare system. So something I get asked frequently, particularly about CADLEC, is, when did it become nonprofit? We've always been not-for-profit. It started as a government, obviously, venture, but has always been, since transitioning, a not-for-profit community hospital. Providence St. Mary, obviously a part of our religiously affiliated ministries and also a not-for-profit. And we do contribute substantially from a tax basis. So if you think about annual taxes, I think last year, Spencer can jump in later when we get to the Q&A, but it was about $85 million in taxes that we as a service area contributed as a not-for-profit that does, we don't pay corporate income tax, but we pay B&O taxes and all sorts of other things. I'm not going to read through each one of these things, but I will say that our biggest focus right now is a few things. One is trying to make sure that we are on a sustainable road, given all the growth we know that's happening in our communities and what we need to be for the folks that we are privileged enough to serve. And so there's a lot of focus on that. From an access standpoint, that means being able to stay solvent enough and make enough of a margin to be able to reinvest in things that we can talk about if there's questions. But we just broke ground on a new primary care facility here in the Tri-Cities. In Walla Walla, we've added some new technology. We had to replace an old cardiac cath lab, and we have some news about, I think, some other technology to help surgery along that we'll be sharing soon. We get a lot of community support for those things through our foundations, but we also need to be able to create enough of a margin to drive some of that. In terms of workforce development and sustainability on that front, really proud of the very low turnover that we have in our institutions compared to a lot of healthcare across the country. It's still not enough. There's still a shortage in nursing, many physician and APP specialties, many of the other things that we provide. We have to have a really competitive stance, making sure that we've got a great work environment for folks, and then making sure we're partnering with folks like you all to sell the community to people in a way that, in my view, shouldn't require too much selling. It's such a great place to live, but I think getting the word out about that is really important. And then over time, as we become more integrated across Tri-Cities and Walla Walla, but also between our medical group clinics and our hospitals, we know we need to have a more seamless experience for all of our patients. So really trying to work towards that promise of more integrated care delivery. And my hope is over time, much more upstream access to things that we have choke points in right now with primary care and other things, so that people don't need to come to the ER shopping for a Ferrari, that you can actually do that a little bit differently. So maybe I'll stop there, Carl, and make sure we have plenty of time for your questions and interaction with the folks in the room and online, but time.
No, that was a great overview. Reza, of course, we met last week and we gave some insights into your presentation, but I think we all, just as wherever you live, we take healthcare to some degree for granted, right? And I think that as we all age, when we're younger, we take healthcare for granted because we don't necessarily need to access it generally. And then as we get older, and I think your numbers kind of support that, but it's a very general question, but what can the community do to support not only, the Providence, Southeastern Washington, St. Mary's and Catholic, but support healthcare in general? I wrote down population health, and you talked about maybe when you don't have access to healthcare, you tend to be sicker when you do access it. So I know it's a very broad question, but what can the community do to support all of our healthcare providers in a better way? I mean, obviously, I think we could talk about policy, we could talk about federal policy, state policy, those things, but is there anything in general we could start the conversation off with?
Sure. I think there's a lot of things. I'll mention a couple. I mean, one, you sort of hit on it right away is, keep yourself well. So,
get sick.
When you notice something, try to make sure that you're taking care of those things as early as you can. I know that can be challenging with some of the access issues, and whatnot, but I think keeping yourself well is always number one. One piece that I'm going to ask one of our team members to talk about here in a moment is we're trying to get the economics kind of right on this in order to continue investing in the community and making sure that we're growing access. There's lots of opportunities to participate, whether it's through volunteering or through, quite honestly, just donations that we get through our foundations to raise money for important capital campaigns and projects. So Lacey, I hope folks can hear you on the online here, but maybe you can talk as our philanthropy leader a little bit about that.
Sure. So because we're part of the larger Providence system, our foundations are hyper-local. So we have 3 within the Catholic and Tri-Cities Southeast Washington service area, 1 in Walla Walla, 1 for Catholic, and then 1 for the Tri-Cities Cancer Center specifically as well. So when we're talking about these razor-thin margins that Reza talked about, philanthropy helps bridge that gap for not just basic care, but exceptional care in our community. So when we talk with community partners, whether that's corporations or generous individuals, about supporting and helping, especially when we're thinking about growing, talking about a lot of capital campaigns, growth mindset to really address those access needs, we're really looking to the community to be our partners in that effort as well.
So one specific example I'll share that we're looking at, cancer care is always a challenge in our community. There's a high demand and sort of limited capacity, and our cancer center, we're going to be looking in the future to expand. Don't know exactly what that looks like yet, but as you hear more about that specific example, there'll be opportunities to get involved. Things like that.
That's great. What else beyond that? I mean, the health side of it, and I know different places where I've worked, insurance companies oftentimes will, give an incentive to change your lifestyle or talk about what you eat or, tobacco or alcohol or like these things. I guess that's a general wellness question, but are there things that you guys are doing or that, the community could take a look at just to, I think about, you see these rankings of who has the healthiest community or something. I have no idea where we rank on that. And I think they look at obesity rates and things like that. But like, are there other things that we could do to, kind of take the pressure off of the healthcare system so that we're not as sick? Or are those sort of like longer term goals that you kind of need to work on the shorter term things first to try to, as you say, return to an operating margin, hopefully, that could support your growth?
Yeah, I think those things that are more upstream, keeping the population well, working with public health, making sure that you've got vaccination rates that are high for things that are typical, the MMR things, and we're seeing now nationwide, some of these concerns with measles and other things. We want to avoid getting into a situation where we have a rush on, like we did during COVID, where there was limited capacity and a whole lot of people needing access to the health system at once. So, those kinds of things, keeping people well are helpful. In our organization, we have, something as simple as an app with points, like you mentioned, for folks for healthy lifestyle related things. I know a lot of companies do things like that are helpful. We have some occupational med services. If there's interest, folks can reach out to me. I can connect you with the right folks. But we're trying to figure out ways to talk to local companies, about those things. And then one thing that you and I have talked about through the lens of TriDec is our need to attract more hard to recruit folks to this community. And I think really having a business community that is welcoming to healthcare workers, maybe partnerships with other industries where we're trying to recruit someone who might have a spouse or a family member who's looking for a job in another sector can be really, really helpful, because a lot of times folks are not going to move somewhere where they can get a job, but their spouse isn't able to work. And so there's a lot of things that we can be doing, and probably stuff we haven't even thought of that folks listening might spark an idea and reach out and say, hey, did you think about this or that? But a lot of it is about trying to build up the workforce that we need. A lot of it is trying to make sure that we are staying financially solvent in a manner where we can continue providing the care and continue growing. And there's all these dynamics to navigate, right, with the insurance, with the health of the population, with other things.
Yeah, I think having access to healthcare myself, your Ferrari story is spot on, and obviously you guys live it every day. But I think that until you need to access it, you just don't know, and it is a challenge. I wonder, are there things that you guys could do? I was even thinking on the transparency of the costs up front. I mean, are there things that you could do to help just increase the understanding of the general population about how does healthcare work? How does insurance work? What kind of insurance do you have? And that wouldn't just be your team, but I think that could be a community-wide thing, right? To kind of raise the awareness of healthcare access, as well as insurance. How do you pay for it? Just the whole gamut.
Yeah, no, for sure. And I think that's a little bit about the discussion today. What
Yeah.
we're trying to do is just talk about some of those underlying dynamics. But for, price transparency, I think that's huge. Being able to know what it's going to cost you when you walk into the Ferrari
Yeah.
dealership. But where it gets complicated and where we're trying to help with this is our financial counselors and patient access folks. They're able to talk specifically with the patient. So if you were to come in, be able to tell you, Carl, let's look at specifically what your insurance is that you have, what you're required to pay out of pocket, what portion the insurance will pay for. And then to a certain level of specificity, you can get into, say you came in for a knee replacement surgery. You can say within a margin of error what that looks like. But obviously with healthcare, there's lots of variables, that of other things that can happen during that stay and so on and so forth. So while it's harder to get sometimes down to a precise number, we can do much better than we have as an industry about, being clear about what it is that the cost is going to be for that care, and doing it by individual based on their particular diagnosis and things that they're going to have to go through. Because Carl Dye coming in for a knee replacement might look very different than a 90-year-old individual with a whole lot of other comorbidities and complications coming in for that. We have to be able to be very clear with folks about what that.
I was going to go back and ask a question on one of your slides. In COVID, I guess I wasn't aware that healthcare in general really had a huge margin hit during that time period. Was that because you had to shut down sort of the surgeries and other procedures that kind of, help give you guys a margin because of COVID? Because in some cases, maybe, so many COVID beds, or just the hospital kind of wasn't open for a while. Is that kind of where that loss came from? Was that the basis of it, or were there other factors that?
It was a variety of different things. So one of them is, as you just mentioned, is, hospitals, just the way the economics work, tend to make more money on surgical types of procedures and volumes, and tend to lose money on more medical types of diagnoses. So when hospitals had to, for periods of time, either shut down or limit surgical procedures, that took a hit. And the reasons that happened were many. Number one, at the same time as the population was sick, our caregivers were getting sick. So the hospitals were shorthanded and having to make the same kind of trade-offs and choices that everyone else did, with a workforce that was kind of crippled because they were out with COVID. And then even folks that were well for a period of time, well enough to work, but had COVID and all the precautions we had to take, weren't able to come back to work. So we were very tight on staffing for a period of time, moving those resources towards taking care of the emergency instead of elective surgeries and other things, which I always struggle with that term, elective surgery. I mean, most people who have to have surgery don't consider that as elective, right?
Yeah.
But what that really means when you hear healthcare people talk about that, things that can be put off or delayed without causing harm, right? So those types of things were impactful. I think another piece was we had some support during the actual middle of the emergency. So during 2020 and 2021, there was a thing called the CARES Act, where the federal government was providing some subsidization, knowing that was happening. That helped. And then if you look at hospital financials in 2022, when a combination of those subsidies going away and inflation really hitting smack head on, that really, that's probably the year, as we look back over the 5, that we were in the lowest point in terms of financial performance. And slowly creeping back from that, but we're going now from a massive loss to a less massive loss, instead of, again, like, we're one of the few that we're very pleased we're able to have a very low single-digit positive margin through, and that's not by accident. It's our team has done a tremendous amount of work to try to right the ship in that way. But those are some of the things that contributed.
And just because we talked about it last week, I want to bring it up while we're here. But one thing that we discussed was, would there be other ways to help people access healthcare? And even with, say, a large employer or a regional employer, maybe somebody that was sort of like in between hospitals, to have some type of I'm probably going to describe it wrong, not a mobile clinic, but even like a pop-up clinic, or, like you could get to know your primary care doc once a week at the place that you worked. I mean, a large employer, we've got folks here from Energy Northwest, WSU Tri-Cities as examples that are larger employees. Like, are there things like that might be cooperative things we can work on to just increase the access to healthcare? And then, I mean, ultimately, I think make sure everybody has a primary care doc, right? Like, I know, because I moved here right before COVID, and, freely admitting I didn't have a primary care doc, and then I got sick and I had to go to, so your Ferrari store wasn't that far off, but we're able to rectify it. But
that's that red car we see parked
yeah,
outside right
exactly.
now.
Yeah,
That's the
yeah,
one you got back.
yeah, red and rusty and those other things. Would things like that help? And I guess maybe you know the answer to this, but like, how many people, say in their Tri-Cities, have a primary care physician versus don't? And is that something, maybe again, that longer term vision that we can work on as a community to try to bridge that gap?
Yeah, I think you're spot on, Carl. And those are all the types of things we need to be exploring more. So primary care, in terms of just the numbers that we have available, we are, somewhere in the neighborhood of, 30 to 50 primary care providers short in the community as we look over the next few years. So we've been really lucky to have some positive recruitment in the last couple of years. Now we're at a point, and some of you may have seen the groundbreaking in West Richland for a new primary care building. We've kind of run out of space, which is good that we've been successful in recruiting. That building is going to allow us to recruit another 10 primary care providers to the community. But I think the other things that you mentioned, some more creative approaches to, aside from in the building, are there things we can be doing to go out to the business community, to other areas? Those are the types of things we want to explore. And I'd love to hear feedback and ideas from folks that are on this call today or elsewhere as we think about those things. Because the one thing we do know is the model that we provide healthcare under really needs to change. And as you kind of hear my bias, I'd prefer folks to have universal access to primary care than having all these folks being driven to our emergency departments. But in order to build that, it's got to be done in a way that's financially sustainable and works for everybody.
Well, because besides the names that I mentioned, I see some other employees around here, but like healthcare and insurance costs are a major employee cost, right? So are there things that we could cooperatively do to kind of bring both sides of the equation down that would work for the healthcare providers, but also somehow either eliminate those longer term costs that the employer's going to end up pick up through insurance or something like that. And I think maybe we talked about having a small group of some of those leaders together to come up and explore those ideas. And we look forward to having that conversation. I think the other thing is, I want to give a shout out to Colin from the Pasco Chamber, but as business organizations working together to help all of our healthcare providers recruit people to our community, and just like showing off our community. I think of Colin and the great work that you guys do with Riverfest as an example. Like I'm just letting it all hang out today, but last year was the first year I went to Riverfest. My son Henry and I had a great time, and such a great gathering as an example of just showing off great things in our community, or in that case, what goes on the river. But there's so many more things that we can do. The founders of our organization called our community the Miracle in the Desert. We really are, but people don't know that until you get here and see it. So I think, and I'm not trying to put anybody on the spot, I'm just saying, I think there's things as business organizations that we could do to support not only you, but then all of our employers that are trying to recruit people here, along as what we're trying to do and recruit companies to just show off the best that we've got, and to make sure that we give a really, really enhanced experience, not like we're trying to fake somebody out, but we're just authentically trying to show, hey, it's who we are and what we do, that helps all of us in recruiting. And I think I'm optimistic that we can work together and come up with some ideas for that.
That's helpful. And it helps us to recruit. And then I think on the other side of that, as other companies are recruiting folks, being able to say that they've got a robust healthcare system here that can take care of this whole variety of things locally, I think that becomes a real big selling point for other organizations and groups. So it's kind of a helpful cycle if we can get that right. On the financial side, I want to go back to that a minute. We're fortunate enough to have our CFO Spencer here, and Spencer is actually from the Tri-Cities and knows the area very well. Spencer, I wonder if you've got any comments you want to share on that as well.
I think that the other thing I would point out that we haven't really talked about is, during COVID, there was a lot of retirements for people that left the market. And so that was a big driver too, for, again, reduced access and wait times and some of the financials that we had to bring travelers in. And so, again, the partnerships we have with Washington State University here and CDC recruitment has been an important part of us getting back to profitability. We've had in the last 2-3 years really good recruitment cycles with new nurses coming in and that. So, but there's other specialties or other types of positions that we still struggle to recruit.
Yeah, and that's a great point, Spencer. And I see WSU Chancellor Sandra Haynes is in the room, who also is the chair of the TRIDEC board. We've been working.
I appreciate you calling her out. I was trying to just kind of let her fly under the radar, but thanks for calling her out. That's great.
But Sandra, I think our partnership with WSU and some of the things we're doing to try to evolve and grow that to expand to more of the nursing school and other things, we're trying to create more slots for nursing, students to be able to be trained here in the Tri-Cities. And kind of to Spencer's point, what are those pipeline things we can be doing? And a lot of that is partnerships with folks like WSU and CBC and Walla Walla Community College, other folks that we work very closely with.
Definitely. So we've been calling people out in the audience, but does anybody have a question here?
Since you just got called out.
Chancellor Haynes.
I think this is an interesting discussion. I'm not so sure it's a question so much as an observation, because I think what you're talking, I think this is a good discussion to be having in an economic development setting. I don't know if you saw the article recently in Forbes that came out to say what are the 25 best places to retire in the United States, or especially if you have, if you're concerned about the cost of living, and Pasco was on that list and was specifically called out, Pasco. So I think as we're looking at what is our future and our economic development, we may indeed have more retirees here. And as you mentioned, Medicare doesn't pay as much as private insurance. So how do we make sure that we're balancing out our economic development here by bringing in companies that will also help keep our healthcare strong? It's an interesting sort of way to look at it, because if we are going to get an influx of retirements, we also need to have an influx of companies that can help support our healthcare system. I will say in this article, and I'm happy to send it to you, is that one of the reasons that they said that Pasco was a good place to retire was the healthcare. So they did call you out in it, or the healthcare systems, and said we had that a good healthcare. I don't know, it wasn't a question, it's just an observation for talking about healthcare, talking about general economic development at the same time, and how interrelated they are and how important they are.
That's a great point. If as you look at more and more retirees, Medicare eligible, going back to the kind of the economics there, we're going to see, and we're seeing this in our Walla Walla community, which isn't growing as quickly as the Tri-Cities, but the band of folks that are growing are the over 65. And so trying to make sure we're balancing improving access to the types of care that older folks need, and we want to keep as local as possible, with the fact that we're getting paid less for those folks that are transitioning out of commercial insurance into Medicare. We have to figure out solutions to that. And there's no easy answers.
Other questions?
Yeah, I do. Just to clarify, you had an expense page that listed travelers, and Spencer had mentioned, was that travelers for physicians coming to kind of fill in the gaps during COVID?
That was largely the nurse travelers. So we do have physician locums that come in that we use, but that number that the State Hospital Association was really focused on was during COVID. There were some other than nursing, so there's other professions like technologists in radiology and lab and other things, but the bulk of that was nurse travelers. I mean, just to put an exclamation point on that one, there was one point during COVID where we were paying as much as $200 an hour for a nurse traveler because the whole country was competing to try to get their hospitals staffed, and thankfully that's come way down. But it's a premium expense that we'd much rather pay our local team if we had enough folks to staff. So it's usually when there's just not enough folks to keep the staffing that you need, and then hospitals look to fill in the gaps with those kinds of travel.
Makes sense. I kind of have a follow-up. Same thing, expenses, which Spencer may be more equipped to kind of crunch the numbers, but the total percentage of administrative expenses, you had mentioned that a large amount of administrative expenses are due to insurance. Do we have like a breakout of what administrative costs percentages are purely related to that sector?
I don't know that we, Spencer, you want to take a swing at that?
I mean, the main administrative costs I think Reza's talking about is really with collections, right? And the back and forth you have to go with insurance companies to not only, get bills paid, but also get them approved and authorized in advance. So there's a lot of pre-work that happens with insurances to get them to say, yeah, okay, you can do the procedure. And then they tend to deny a lot. And you have to work with them afterwards to say, well, you already approved this, and we did what we said we were gonna do. Now pay us what contractually you're obligated. So that's where a lot of it is. And I don't have a number of that, but we have a fair amount of caregivers that are just focused on getting paid. And for, again, it's not, in a world where we have so much electronics, you think you just, send the bill electronically, you get paid electronically, we're done. There's a lot of manual intervention because of this back and forth game that's played.
Yeah. At a more global level, there's a book I always recommend to folks when they bring this up, and my team is probably tired of hearing this, but there's an economist named Hugh Reinhardt who put out a book. It actually came out just after he had passed away in about 2019. So it's a little bit dated, but he had a lot of really good information in there about the economics of healthcare and what's really driving some of it. And I can't remember the stats offhand, but he calls out specifically kind of a percentage higher that the administrative costs in the United States are than most other countries, precisely because of these things that, that Spencer mentioned and other factors that make it more complex. So if you're looking for a interesting read, Hugh Reinhardt's book, Priced Out, highly recommended. It's got a lot of.
Thank you.
I think it's a good point, though. A long time ago, I worked for a company that sold into the grocery industry, and it's an interesting analogy, I just have to say, because if you sell something into the grocery industry, traditionally there was this game of discounts and advertising promotions and things like that. So, grocery companies, there's a ton of consolidation there because of companies like Walmart and other ones that don't have any overhead, because they have a different model. They're like, just give us your lower price and we'll promote it. We'll do whatever. They don't play this kind of historic game that doesn't really, if you looked at it today, you wouldn't create a system that's set up like this, but I think it is to some degree kind of an analogy that just like, that's the way that we evolved into how do we pay for healthcare? How do we have insurance, realizing, Obamacare and stuff like that. There was a choice to continue to use insurance companies. And I think what we all forget sometimes is that when you have like any type of an investment or retirement account, a 401k or anything, they almost always blend these portfolios into insurance companies who make money on that kind of funds all of our retirements. Like it's this cycle that I just bring these things up not to offer a solution, but just to say it's really, really complex, and it's hard to just pick it apart and just go like, oh, well, if we didn't have insurance, well, those things aren't going to happen. It's just an integrated part of our economy, really.
Yeah.
I mean, in so many ways. And so looking for these other ways that how can you incrementally make some some efficiency increases is kind of sounds like what you guys are forced to deal with, right? Like you can't, it's not a clean sheet. You can't just start over. You gotta work with what you got.
Yeah, and that's the crux of the challenge is we can't change this complicated system. I mean, we'll use the analogy of the IRS tax code. I mean, it's complicated, and then every time something gets changed or added, you've got to, an accountant has to relearn how to navigate all that.
Yeah.
It's a lot the same with our system. So the Accountable Care Act, I described that as sort of it was a nice patch on a very complicated system. It didn't fix any of the underlying dynamics, maybe a couple of things with pre-existing conditions and others. And it did kind of bend the cost curve down a little bit, but it didn't really solve the underlying challenges that we talked about that still exist that we have to navigate for sure.
Definitely. Any more questions from Yeah,
I just have
Tiffany.
one. I know that during COVID, the government was funding a lot of the hospitals, but where did all that funding go for you guys? Did it help you in any way or, I mean, your deficit's huge during COVID times, so I just wanted to kind of understand where.
Yeah, it really helped in 2020 and 2021 when we were getting some help from that. And Spencer's probably better positioned to talk about specifics, but yeah, we want to hit that one.
Yeah, I mean, I think, some of the numbers that he showed from the State Hospital Association showed, big losses in 2020 and 2021. They would have been substantially bigger without the CARES money, yeah. And so for Cadillac specifically, I think we had a slight profit in 21 thanks to the CARES money. We would have a pretty significant loss in 21 without it. So again, covering the inflation costs, the traveler costs,
Right.
all those different things we talked about.
So we've had some of the same staffing and hiring challenges you've had, and it's like, look over the last 5 years, where we've ended up today is we have the people we want, but the experience base is way down. So, where employees maybe had 20 years of experience on an engineer, now maybe it's a new college graduate. So you see the same thing in the medical profession, and if so, we've had to invest a lot of extra time, effort, and dollars in, say, on-the-job training or development of the existing staff. Do you have the same struggle?
Absolutely, 100%. And I think across really a lot of the different folks. So if you think about many of the physicians that have retired over the last number of years that came up during a certain time, and this is one of those things where as you get some of the newer with physicians coming out of training and so forth, not only are they lesser experienced and of course need to build that up over time, culturally there's been a shift, and I think some of that's been good, where work hours have been limited for residents and programs and things over the last couple of decades. And I think many of our physicians and providers are just looking for a better lifestyle and balance. And so oftentimes you get somebody who's retiring, and you've got to replace that position with more than one individual in order to have the same level of coverage, not just from the experience factor, but because of just the lifestyle and the folks that expect something different. And again, I think that's probably a good thing on balance. Similar outside of the physician and provider settings, we had a lot of nurses, a lot of other folks during COVID who kind of said, okay, they might have worked another 5 years, but they were so tapped out by what was going on. They retired from healthcare, or there was kind of a reset. Y'all probably remember this, where people were reflecting on what they want to do going forward, and there were all these opportunities to work remotely and do other things, and we'll see how things shake out in the years ahead. But a lot of that shift, we're trying to recruit folks in to fill positions, and as many people that we can get out of programs that are graduating, we'll take them, and we're happy for it, but they don't have that level of experience, and we don't have as many people now available to precept them that have the experience still within the walls of the institution. So all those dynamics are very, very much playing out for us as well. And that's true of administrative roles. It's true of a lot of things.
Glad to hear another one.
Yeah, not long, Bob.
Anyone else? Any more questions? Is there anything else, Reza, before I start asking you about guitar lessons or anything else?
No, just thank you all for your interest in this, and thank you, Carl, for all your support. And Tridec, I think there's many reasons why we feel like it's a privilege to serve these communities, and hopefully despite the fact that we fall short, we know on the access front, especially just trying to keep up with the growth and a lot of things. Hopefully the community feels similarly about us, and looking to just continue to partner to grow this and improve things the way we all hope they can.
I did actually have one more question. In areas like, I just think of like Florida that have huge retirement communities, like how does healthcare exist in some place that's like dominated by Medicare and Medicaid patients? Because, I mean, are there different models out for hospitals that have a higher percentage rate of those, the government pay programs?
Yeah, that's a complicated question, but
Okay.
there's many regional differences. If you look at, so I'll start with just kind of geography.
Yeah,
If you look at the West Coast and this part of the country, the cost to provide care is significantly higher than, since you call that Florida. Some of that is the regulatory environment. There's a lot of regulation in Washington State, Oregon, California,
Okay.
in our particular states where we operate, that just causes the cost to be a little bit higher. The cost of living too, in terms of this part of the country, is higher. So wage rates tend to be higher. A lot of the things that you see in the kind of the middle band of the country, in areas where often you'll see a concentration of for-profit healthcare systems, or dynamics that allow them to
Yeah.
drive a little bit more of a margin
Okay.
and kind of focus in those ways. I think there are also, probably not time to get into it here today, but there are financial models related to taking care of Medicare patients on a capitated basis, where a primary care group might get paid a fixed per member per month to care for a
Oh.
population, and then the incentive becomes to provide good care as far upstream as possible, to keep them out of the hospital,
Oh.
to keep them away from having unnecessary tests and admissions.
okay.
That can be helpful too. We're not as far along in some of these markets with that, but that, I think in the future, there may be opportunities to get into more of those financial models.
And are those programs that are kind of sponsored by the government?
Yeah.
So there is more of a proactive healthcare approach to an older community to be able to do that?
Yeah, CMS has these models with Medicare shared savings and other things that
Okay.
that are being either piloted, or in some markets are a little bit more mature for both Medicare and Medicaid in different ways. And
Okay,
they're not global enough, I guess, to say,
Yeah.
hey, the country has moved kind of in this direction. We're still very much on a fee for service,
Sure.
incentivize people to provide more care. But we'll see what happens in the years ahead. Hopefully it will evolve.
I think those are interesting, just because I think from a wellness and a cost of healthcare, whether it's for an individual, for an employer, or, from a demographic population within our community, and thinking about what are some things from a whole community perspective that we can work on together, I think those are really intriguing, because I think there'd be big benefits. And then the more things that we can do that, just like anything else we're talking about, whether it's the tours or anything else, we're recruiting companies or people, if we can do something together in healthcare, I think it just gives us one more thing to kind of like, I don't want to say show off to people, but just to put our community up there, say like, hey, we're working on this together. That would be great to see what we can do.
Yeah, agree.
Yeah.
We do have two questions.
Oh. Questions from the internet. Oh. Here we go. As we work to build more equitable and inclusive career pathways in healthcare, what challenges are you facing in, oh no, see if I can, sorry. In attracting and retaining diverse talent, particularly in underrepresented communities, and how can we support those efforts through targeted workforce programs or partnerships?
Great. Yeah, great question. I can talk a bit about what we're doing internally, and then maybe you can comment on some of the broader partnerships. So one of the things right now that we're doing with all of our leaders, particularly focused on those that hire a lot of folks, is a program we call Hiring for Excellence. And it's really a way to help our leaders level set on looking at candidates for jobs across every walk of life, and helping to eliminate any maybe inherent biases they may have that may contribute to certain groups not getting to the next level in an interview and being considered. And so trying to just be very fair and equitable and attracting more candidates that way. And so that's been useful. I think as we look at our leadership ranks, and particularly when you start going above director and higher, we see there's some opportunity. And some of that is just casting a wider net. So in our community where we don't have as much diversity or folks with some of these particular skills and training, we're trying to look externally. I mean, I was recruited from out of state to come here. There's numerous folks on our team. So I think it's a lot of things that we try to do. Some of it's the partnership with the schools, I think, and looking at are there ways that we can help the schools through scholarships. And Lacey, I don't know if you want to talk a little bit about our scholarships through the foundation and how we kind of help get people that might not otherwise be able to get into colleges, but I think that's a really worthwhile thing to highlight.
Yeah.
Yeah, we have a great partnership with WSU Tri-Cities and CBC to work with social work programs, our nursing programs, to be able to highlight those that may not be able to afford. Providence does have a reimbursement program, but a lot of times that doesn't cover books or upfront costs that have that low barrier of entry. And so the foundation kind of helps bridge that gap. We also have a Latino trauma support program through our emergency department as well. And so we look to hire individuals and consulting to be able to help support those individuals in need with trauma support.
Yeah, that's great. Last question, and this is from Cynthia Garcia from Benton Franklin Workforce Development Council. She says, labor market data shows that healthcare occupations, especially in nursing and behavioral health, are among the most in demand across Southeast Washington. What workforce analytics or projections is Providence and Southeast Providence using to anticipate future shortages? And how can we, I think from a Workforce Development Council, better coordinate with your team to align training investments and local pipeline strategies with those trends? So I think that's an offer from Cynthia. And I know I sit on the board, and I think anything from that regional workforce perspective we could do.
No, I'd love to connect with her offline, connect her to our HR team. So there's a variety of things that we have in terms of analytics, and some of this will be probably unsurprising to you all. You can look using forecasting tools at a population base. I'll just use physicians as an example. So we have a needs assessment that says, hey, for this population that we have with these particular characteristics, here are the types of things that they are going to need in the future in terms of healthcare, and you can project the specialty need and shortages and so forth. So we have a very detailed kind of look at that. On the HR front, outside of providers too, we kind of look at demand studies for, I'll use number of hospital beds as a proxy. You kind of say, here's the population and here's the number of hospital beds you think you need based on per capita utilization. And then you can back into, in order to support staffing those beds based on current staffing ratios, here's how many of this and that you need. And the short answer to that is it's not enough in terms of what we're recruiting currently. So all these programs that we're focused on trying to build up that workforce, trying to attract as many folks from different diverse walks of life that have an interest in relocating here and becoming part of our team. It all matters. It all counts. And I would love to connect with that.
That's great. We'll make sure we make that connection. Okay. Now we've exhausted all of our questions. Reason I didn't even talk about.
You're exhausted?
Well, yes. Just the questions. I'm doing all right.
All right.
I have good access to healthcare, so I'm good. Thank you. Thank you. Yeah, no, I think it's when we talked about that, this is the discussion we wanted to have, just to, have a platform that most average people, business owners don't understand the challenges that you guys face, and then even the opportunities that we as a community have to come together to support healthcare and just, make Tri-Cities an even better place to live. So appreciate your support, sponsorship, but then your time today, Reza.
Yeah, thank you, Carl.
Okay. Right. Thanks everybody for joining us online. Thanks everybody here in person. Our next Donuts in Development will be the first Tuesday in June, second Tuesday in June, which is June 10th. I'm going to make a date up. Okay, thanks, Tiffany. And we are going to have Avalanche Energy, which is a new fusion company that's building a facility in Richland. So anybody from our construction and engineering community, they want to meet local contractors and engineers. So make sure you show up in person or join us online next month, second Tuesday in June, where we'll have Avalanche Energy on. Thanks everybody for your time. Appreciate it. Have a good day.